Oh, I have to get myself out.
Hi, everyone. I'm Leslyn Keith. I'm president of the board for the Lipedema Project, and I'm also the director of research. And I get together with you twice a month to talk about different papers and different studies and things that are coming out of relevance to lipedema. And so I got another really good one today that I want to talk about. If you're here and listening, please put something in the post where you are in the world and anything you want to say, any kind of comments. As I start going through this paper, which I think you'll find very interesting, go ahead and post questions or comments about it. I always love to hear from you. So the paper I'm going to talk to today, you can see it down below, Persistent Lipedema Pain in Patients After Bariatric Surgery, a case series of 13 patients. And so this just came out in January of 2022, and I didn't even know about it until Dr. Gabrielle Ferber sent it to me and alerted me to this paper. So thank you, Dr. Ferber, for sending it, because it's a really important piece of research that I want to share with you. It was done in collaboration between a group of clinicians and researchers from Germany and Austria. They were all from two clinics actually in Germany. And they were specifically lipedema, lymphedema clinics. So what was the purpose of this study? They wanted to raise the awareness about lipedema in general to the obesity medicine community who unfortunately were treating people with lipedema but unknown, and treating them as if they had simple obesity. And one of those treatments would be bariatric surgery, and the outcomes are not as good after surgery. And so that was their theory going in, that this is a problem. And so what they did is they went back and did a retrospective chart analysis. They went through every patient that they had seen in their two clinics in Germany from January to October of 2020. And they were specifically looking for people that had, in their past, had bariatric surgery before they knew they had lipedema. So they scoured, 10 months of charts to find just those patients. And so I wanted before I think my okay, here we are. I think I'm back. I hope I'm back. The first term is lipohyperplasia dolorosa. Hyper means I'm okay. I know that I don't have a good internet connection and I keep on freezing. I am turning on my hotspot, so hopefully I will be stay connected. Don't know why I'm freezing. Sorry about that, guys. So the first term was lipohyperplasia dolorosa. And so the first word means excessive fat tissue, as we see in lipedema. And the second word, dolorosa, actually it's the literal translation is road to suffering. And so the dolorosa actually refers to pain. And so the authors of this paper were talking about using this term, lipohyperplasia dolorosa, instead of lipedema. So if you do read the paper, you will see that that term is used. And then the other two terms or concepts I want to talk about are excess weight loss and total weight loss. And so what they were looking at in this study was the percentage of excess weight lost versus the percentage of total weight loss. So for instance, if we have someone who is 100 pounds overweight and that person after their bariatric surgery loses 70 pounds, they lost 70% of their excess fat. So, but if you then look at their total weight, and so that same person actually weighs 250 pounds, they're 100 pounds overweight, and after the surgery, they lose 70 pounds. And so now we're looking at 70 pounds. What's the percentage of from 250, their total weight? And so their total weight loss was 70 pounds. And so that now it's 28%. So just those are things to think about. So what's the data they collected in this study? They looked at typical stuff like height and weight. They also looked at what stage of lipedema they were at, what were their lipedema symptoms, what's their family history of lipedema, and what are their comorbidities that they have. They also looked at pain, and they used a pain scale of 0 to 10, and they wanted to know what their current pain was. And then they asked them what their pain was on a scale of 0 to 10 prior to having their bariatric surgery. And then they also, in order to calculate the excess weight loss and the total weight loss, they were looking, they asked their bariatric surgeon what their height and weight was prior to the surgery. So, then they calculated those two things. So who participated? When they went through these 13 charts, they ended up with us 13 women, and they all, 100% of them had a tendency to bruise easily. 9 out of 10 of them, or 69%, had a family history of lipedema. So that was interesting. 69% had a family history, but it wasn't all of them. And 10 out of 13, or 77%, had no comorbidities we commonly associate with obesity. They didn't have hypertension, they didn't have diabetes, things like that. And we commonly see that women with lipedema don't have those obesity comorbidities. And 6 out of 13, or 46%, had actually an issue with recurrent skin infections on their inner thighs, which is typically more associated with lymphedema, but they had that issue coming up with almost half of the participants. And then BMI and pain prior to surgery. BMI was 50. And so 30 means that you're obese, 40 means morbidly obese. So the average BMI was quite high at 50, and their pain was also quite high at 7.3 out of 10 being the worst. And then post-surgery, and it was a mean of about 20 months post-surgery, their BMI was 32, so went from 50 to 32. Their pain was 7.9, actually went up a little bit after bariatric surgery. And then the excess weight lost was 73% of however much they were overweight. But when we looked at the total weight loss, the percentage of total weight loss, 37%, still both very high numbers. They did show pictures of a couple of the women and how their body changed after their bariatric surgery in the article. There's a couple of limitations to this study, though, as you might think. So there might have been a selection bias in selecting people that were at a lipedema clinic. So that may be an issue. And then the other thing is that the women were having to recall. So when you're going through and doing a chart review and you're asking the women to rate what their pain is now and then recall what their pain was prior to bariatric surgery, then there might have been a little bit of a recall bias. And so we don't know how accurate their estimate was of their pain. So might have been bariatric, we just don't know. And then another issue was it's a small sample size. It was only 13, but this is actually twice as big as any other study on this topic had been done before. So the authors, one of the things that they concluded is that this lack of awareness about lipedema in for medical providers in general, but specifically with obesity medicine doctors and bariatric surgeons, this can really lead to inappropriate treatments, or at the very least, poor outcomes, that a patient may go into bariatric surgery and expect to not only lose weight, but also have a resolution of their other symptoms, including their pain. And by this study, it shows that it didn't happen. And actually their pain, average pain, went up slightly. So that would be a disturbing outcome of the study. So you might get less than promised results from doing a bariatric surgery because there wasn't the awareness that you actually have lipedema, maybe along with obesity. So they said, how can we make this better in practice? So here's some of their suggestions. One is that when you do your initial assessment of the patient, you should be doing BMI, yes, but also waist to hip and waist to height ratio, because that tells you where the excess fat is. BMI does not tell you where the fat is. So we should have all those other calculations as well. We should have body measurements, also another way that tells us where the enlargements are. We ought to look at family history. Are there other people in your family that you look like, that you resemble, that could help identify possibly lipedema? And then also look at those comorbidities. There's comorbidities that are commonly associated with simple obesity, and these are not commonly associated with lipedema. And so if you have someone with a really high BMI and a really low waist to height ratio, then they don't have any comorbidities associated with obesity, then you start to think maybe they have a lipedema diagnosis as well. And they said you should be really measuring and monitoring their pain and hypersensitivity levels. So keeping track of that. And then also noting how they respond to the surgery. Did they lose weight disproportionately? What they're finding with this chart review is that although women with lipedema lost weight with bariatric surgery all over, they still were disproportionate. They still had an enlarged lower body. Some of them still had a wrist or ankle cuff. So the features of lipedema were still present, and definitely pain was not diminished at all, which is not a good outcome. And so now when you have someone who has both lipedema and obesity, how do we treat both conditions well? And so they had some suggestions for that as well. And they said that before surgery is considered, patients should receive, get this, nutritional counseling and CDT, complete decongestive therapy. Remember, that is manual lymph drainage, a specialized massage, skin care, movement, exercise, and compression therapy. And so they're saying we should be doing these conservative measures and nutritional counseling before we consider doing bariatric surgery. And they also said, and I put this in quotes, this is exactly what they said, an anti-inflammatory and weight-reducing diet should be used. And we know at Lipedema Project and Lipedema Simplified, what seems to be working the best for lipedema is using a carbohydrate restriction, sometimes all the way down to a ketogenic levels. So that's interesting that they kind of alluded to that. And then another way that they said that we need to, in order to treat both of these conditions of obesity and lipedema concurrently, is it needs a multidisciplinary approach that says it should involve lymphologists, physiotherapists, nutritionists, and surgeons, and both surgeons who do liposuction and bariatric surgery. So really much more multidisciplinary and holistic approach to treating both of those conditions. Here's the protocol that they use in their own practices. If the person has a BMI up to 40, so 40 and below, they're going to start with liposuction, And then they're going to treat, so they're going to do liposuction for the lipedema. And then they're going to treat the obesity with diet and exercise and bariatric surgery if necessary. So they're starting with treatment of the liposuction, treatment of the lipedema first. This is interesting because it's completely opposite to what we saw another case study report of 5 case studies by Dr. Alexandro Amado from Brazil, a surgeon in Brazil, and he suggested start with the conservative treatments of diet and exercise and CDT, get some improvements in the skin health, the tissue health, and the overall metabolic health, and then do the liposuction. So 2 different approaches. And then the protocol that these authors use, if you're over 40 BMI, they want to treat the obesity first. And in this case, they want to go ahead and do the diet and exercise for 6 months, and then bariatric surgery if it's still needed, and then do a liposuction for the lipedema. So I got to think that most of the authors on this paper are surgeons because they really want to bring in this surgical alternative. The lead author is Manuel Corneli from Germany, and he's written a lot of papers on lipedema. So I thought that was really interesting. And I just want to look at some of these comments. Got some from California and someone from Nova Scotia. Julie's here from Camarillo, my neighbor, and Winetta from Anchorage, and Kim from Canada, Peggy from Louisiana, all over the place. Cheryl in Ontario, Canada, and Jeannie Lewis from Sacramento is here. And then Peggy says, my upper arms are still disproportionate from the rest of my body. I dropped from 360 to 112. And Peggy, if you're saying that you had bariatric surgery and this was your outcome, that agrees with what this paper is saying, is that you still have that lipedema shape, even though you lost a lot of weight. But more importantly, that a lot of those other symptoms like easy bruising and severe pain do not change at all, even though you've lost a tremendous amount of weight. So that is very telling. I've heard of other presenters and papers, they're talking about, no, look, bariatric surgery really was the answer because look how much weight they lost. Look how much smaller the person is. But did they talk to them about their symptoms? Did they talk to them about their quality of life and how things are going? Because then we're seeing that maybe bariatric surgery is not going to be the first answer to someone who has lipedema, definitely not for someone who has just lipedema, but when it's lipedema and obesity, it probably is not going to be, shouldn't be the first thing you do. But many people have done it because they had no idea they had lipedema. So yeah, Peggy says that her surgery was 25 years ago and gained a lot of that back. Yeah. So, and that is also, some people are saying, well, that no one reverses their bariatric surgery. They don't regain the weight. And we know that it's often that unless you change the way you eat, along with having the bariatric surgery, quite often you will regain it. And there could be other complications as well as with absorption of various nutrients and things like that. So it's definitely something that is going to be useful for a certain population. It should be at least in the realm of possibilities of things that we consider. But I don't think it should be the first line. I think there's a lot of other things we can do before we go to that. Yeah. Peggy, you had an injury that caused your bypass to be undone. Yeah. Make sure that you get my email and email me with comments. If you have any questions about this article, or if you have a suggested article you would like me to discuss next time, I do have they're all kind of lined up. I have quite a few articles backed up, but I will get to yours too. So email me at leslyn@lipedemaproject.org. I love your comments. I love hearing from you by email. So feel free to contact me with any comments or questions. I definitely would like to do that. A Facebook user says that I had bariatric surgery in 2019, still have the shape, even though he lost 100 pounds and plateaued. And I've been told I can't have liposuction until I get under 35. And currently it's 36. Yeah, and you have the arms involved as well. I will tell you, there's plenty of really good surgeons that are not, they don't use the BMI as the bar on whether or not they will do liposuction for lipedema, but it really behooves you to do your research and talk to a lot of surgeons before deciding if that's going to be the best thing for you. I have done, reviewed several papers on liposuction, and one of the main things is that the pain quite often responds very, very well to liposuction surgery, but we're also finding that if you don't also, as with bariatric surgery, if you don't modify how you eat, that a lot of your symptoms will return after a liposuction. So it's got to be a whole plan. So one other thing I'm going to talk to you about before I go is make sure you check out our Lipedema Awareness Month. We're going to do a lipedema challenge, and it's going to be June 7, 8, 9, 10, and 14 with a couple bonus days. Go to this website and check it out and learn more about this. It's free, although we do have an option to upgrade for some bunch of other extra stuff if you want to. But check this out. I think you'll find it's going to be very valuable during our Lipedema Awareness Month, and hope to see you there for that. Thank you for joining me today for this research update, and I'll see you again next time. Bye-bye, everybody.